Good afternoon, everybody. Welcome to our webinar for today. My name is Tom Piotrowski here at Clarity Group. I'll be our moderator for today's event, and this is an open forum on patient safety and risk management for critical access hospitals. So on behalf of the folks here at Clarity, our panelists, and all of us who do work in small and rural health, welcome to today's webinar. I know many of you have experienced or have worked with Clarity in one way, shape, or form. Some of you have not. So we have a couple of slides here at the introduction and then an introduction to the actual program before we introduce our panelists. So we'll go through these somewhat briefly, but just to give you a sense of who Clarity is and what you can expect from today for our webinar. Clarity Group was founded in 2002, and it really is a company that's focused on risk management, risk, quality, safety in the healthcare arena. We are a leader in healthcare resource specializing in enhancing patient safety and quality of care. And through through that work, we have a suite of services which really includes three suites of services. The Healthcare Safety Zone Reporting System, which is a total event reporting system to help with managing many aspects of quality and safety. And we also operate a patient safety organization, and we also service risk quality safety consulting for a variety of risk management activities. Our vision really is about preventing harm in any way, shape, or forms that we can do that and wherever our patients are. And so the way that we do that is our products and services focus on improving total care delivery to patients. We are able to, or at least support and be able to respond to being proactive about many risk mitigation activities, being able to reduce harm, being able to create a learning environment, and what we learn from then be able to promote and share that evidence across the country. We are a proud provider of risk quality safety services for many critical access hospitals across the country. And one of the programs with which we've done that is a program called the Benchmark for Excellence in Patient Safety. And so many of you have potentially heard of this program. It is in many states and a few hundred healthcare providers with the attempt to create benchmarking across the country. And aspects such as falls and the many elements of patients falling, medications and the many elements of medications. So very proud to support and help and service small and rural health as it relates to advancing quality and safety. And it shouldn't be underestimated. I mean, the work that happens in small and rural health is pretty wide and expansive. And as of January of this year, you see the percentage here on the screen, a little over 21% of U.S. hospitals are CAHs. And some 51 million Americans rely on small and rural health care every year. So the work that we do is certainly a pinnacle and a point that really should never be underestimated. And congratulations to all of us who do the work to support small and rural health care delivery. So what we really want to talk about today, and what you'll hear our panelists talk about, and the work that Clarity does, is really about the ability to manage the various aspects of safety and care delivery. And I just have a little bit of a comparison here. We always like to, where we can, try to not duplicate work or cross over with regulatory bodies, with accrediting bodies, with other aspects of folks who help us to advance the care delivery process. On the left-hand side here, you see the Joint Commission patient safety goals for 2019 for small and rural health specifically. And then on the right-hand side is a lot of the key areas, not all, but some of the key areas that we work with, things that we hear, some current hot topics, if you will, in small and rural health. So everything from overall reducing risk exposure, so to mitigate our risks of medical malpractice lawsuits, for example, and just general risk as it relates to patient safety and preventing patient harm. One of the ways we have to do that is staff credentialing, being able to understand that our staff need to, be credentialed appropriately. So how do you track, trend, and monitor those sorts of activities? How do you identify patient problems or patient concerns, and how do you manage the data with respect to those areas? And then, of course, specifically our clinical topics and many of the topics that we have been capturing data on for a very long time. So medication management, diagnostics, including diagnostic delays, response times, turnaround times, infection control and prevention, pressure injury, and of course, the ever popular patient falls. So our goals for today really fall into these three buckets. One is to identify the needs for patient safety initiatives. How do we do that? What is the lens with which we need to view across our organization as it relates to our patient safety initiatives? How do you choose and how do you focus on initiatives? And once you've identified those things, how do you track and trend those initiatives? How do we do data analysis? And it's not just analysis to identify something. You have to create interventions, and then those interventions need to be monitored and surveillanced to make sure that those improvements are effective. And then it's the patient safety impact, creating the awareness, changes that you see across the organization, and then how do you sustain those changes to make sure that that safety path you've chosen is really moving forward in the appropriate direction. And we call this creating this cycle, and it's a cycle of positive change, and some of our founders for a lot of the work that Clarity does when we're on our call today were really the genesis of this model, and it's a very iterative, very learning model. I think it's perfect for what we're talking about today, and it's an appropriate safety model that really is applicable to work that you all are doing today. And it is about awareness, it is about data and using the data appropriately, seeing the changes in the interventions being applied, and then this cycle repeats itself. And you'll hear some of our speakers talk about the use of data, how patient safety affects everything that we do in healthcare, and it's really about this sort of modular approach. So critical access hospital, in the context of patient safety, and I know it's hard to separate, because a lot of us do think that patient safety is at the core of everything we do. But I wanted to give a couple of questions here, and things that we want you to be thinking about when you hear our speakers present, when we have the question and answer session at the end of the webinar. These are some of the things we want you to ask yourselves and think about. How do you measure and track defects? How do you know once you've implemented something, how do you know that that process has been successful? What are your key data sources? Where does your data come from? How are you using that data? And then my personal favorite here, how can you compare your successes and best practices to other CAHs? How do you know what you've done is above the mark, above the benchmark? And don't fall into the silo trap of, just because you have incremental improvements doesn't mean that it can't be even better than that once you learn from others. So just a couple of questions that we want you to be thinking about for today. And I have the privilege of introducing our three panelists. Before I do that, just a couple of housekeeping tidbits here. We are recording this session, so you all are aware that this is a recorded session. All of the viewers are in listen mode only, and on the bottom right-hand side there of your GoToWebinar, you should see a little questions option there. If you just click on that questions and then you type in a question, we'll be able to view those questions, and then I will read those questions to our panelists who can answer those questions. We will save all the questions till the end, so we have three panelists. We'll introduce the panelists. They'll have a few minutes to speak, and then we'll have a question and answer session and plenty of time for questions and answers at the end of our panelists' presentations. Okay, so as I promised, a brief introduction to Clarity Group. Now I have the honor of introducing our three panelists for today. Our first panelist is Diane Bradley, and Diane Bradley is currently an independent healthcare consultant with quite a bit of experience. She's 35 years of management experience in acute care, long-term care, and behavioral health settings in a variety of leadership positions. She's also served as chief nurse in multi-hospital systems with a variety of experiences in the administration on the health system side. Diane's also served in the U.S. Army, so thank you for your service, and has advanced into chief nurse at a 400-bed field hospital. Most recently, Diane has served as interim CEO for a 115-bed rural PPS hospital and is currently working as an independent consultant, focusing on many of the aspects that we really want to touch on today, including the patient experience, empowering staff, the alignment of quality initiatives, career coaching, effective planning and implementation of populations through transformational care coordination, lots of busy things there, data analytics and decision making, and of course facilitating innovation and ideas to improve the redesign of care delivery. So Diane has got quite a bit of experience in many areas. Today, Diane is going to speak to us a little bit about how patient safety really is at the core of everything in healthcare delivery. A little bit of data and the data use as it relates to compliance, ways to enact service recovery, ways to interact with patient safety committees, and some principles and commitments to the environment of care and environment of safety. And so with that, Diane, I'll turn it over to you.
Thanks, Tom, very much. And welcome, everybody, to this informative webinar. I just want to give you a little bit of rationale why I selected the information that Tom just described. It was primarily based on my most recent experience as an interim CEO and actually changing some observations that I had as a consultant. And some of those we'll get into. But first and foremost, when you look at patient safety, when we look at patient safety, in my opinion, it narrows down to one important statement, and that is doing what's right. And my philosophy throughout my career has always been, I don't believe that anybody who is a provider, whether they're a physician, nurse, laboratory technician, whatever the title is, that I do not believe that anybody goes to work with the intention of doing harm to anybody. It happens, it's unfortunate when it happens, but I think that the primary message here is that what are we going to do as healthcare professionals to mitigate harm to patients? So with that said, let me talk a little bit about other philosophical feelings that I have. First and foremost is that if you know the conditions of participation and the standards, regardless of who you're deeming authority is, that you can definitely see a trend or a theme that says the conditions of participation or the standards are woven into everything. For example, if you narrowly look at, say, one of the conditions of participation, patient referral and transfer, think about that for a minute. If you look at that globally, would you think that, what would you think is related to patient safety and or risk? I look at the ability, what providers an organization has, and why we would refer and transfer someone to, say, a higher level of care. So that is woven into that standard. Another is that critical access hospitals have 25, no more than 25 inpatient beds, and how those inpatient beds are used. So I look at hiring of personnel, who's delivering care, how you're delivering care. So again, falls back to weaving patient safety into that standard. I give you another specific example of, again, a recent experience where we were surveyed and we were talking about OR fire safety. And the OR director definitely had done fire drills throughout the year. However, when the surveyors looked at the sign-in sheets, there were no surgeons listed as participating. And as a result of that, that we were cited for not having the appropriate participants in the drills. The other thing I look at, and I like to consider myself to be a futurist or a visionary of healthcare after all these years, is do you look at things like physician burnout, provider burnout? It's a big topic today in the literature about how that affects patient safety. I also think through workplace violence, and that clearly, without doubt, affects patient safety. And then, you know, the other more global perspective is how we hire people to take care of patients, whether it's from a distance or whether it's at the bedside. So those kinds of things are what I'm thinking about in addition to all of the other patient safety factors. So just from a statement, I would say that how are you looking, in addition to the questions Tom posed earlier, how are you looking at a culture of interdependence, of safe, high quality, and consumer-centric care? And what does that mean? What does that mean for you as an organization? To me, it ultimately influences consumer engagement. Are you going to be the hospital of choice for your community, or will they have not so good things to say about you on Facebook? It also influences trust, which means if I trust the organization in the community where I live, then you will continually improve your opinion of the hospital. And if you use data appropriately, the data should help you improve the care. So let's move on to the importance of data. Hopefully you see that there is, and I would assume there's a number of quality individuals on this webinar. So why is it important? How do we analyze what we're doing in a way that complies not only with the conditions of participation, but again, doing what's right and continual improvement? So I was reading the other day a report that was done by KPMG, and it was done in 2018. This was really interesting to me. And it was a survey that found 78% of CEOs needed to make a critical decision, but overlooked data-driven insights that were out there because they were contrary to the experience of the CEO. 78%. So instead of looking at the data, they base their decisions on their own experience. Well, I'm here to tell you that most of the CEOs in the country are over the age of 40. And with that in mind, and with the generations that we deal with in healthcare today, you can't only depend on your own experience. You need to look at data. So here's some insights that I'd like to offer to you. First, make sure you have high quality data, or what I refer to as clean data. So you look at a variety of systems across your enterprise, and do they all talk to each other? And I would venture to guess that that's not true. They do not talk to each other. So how are you extrapolating data from all of those that will help you make meaningful decisions? Do you review data and performance metrics across time? In other words, how do you zoom in and zoom out? And number 3 is, how do you share key performance indicators across all levels of your organization? And one of the things that really attracted me to the Safety Zone portal was just that. It allowed us to do that in a more comprehensive way than we had before, which were some of the ways for the critical access hospitals I have worked with was manually. And this certainly was a great platform for specific metrics. Also, how do you develop cross-functional collaboration? Who owns the outcomes? So I'm talking about accountability and empowerment. And accountability today, all of you know this, is huge. And how do we encourage accountability? We can't make people be accountable, but we can encourage that. And how do we empower them to do that? How do we communicate information? To me, it's the number one point that I would like you to take away. Communicate, communicate, and communicate. And that's the primary way of creating transformational change. And then finally, how do you trust the insights from the data? not necessarily from the experience, as I mentioned earlier. And how do you course correct? Do you go a year without course correction, or do you look at your initiatives and your metrics frequently to course correct? One of the things that I've always believed in is integrating safety or quality, whatever way you want to globally discuss that, with your strategic plan. So I think that's an important message. It should not be different from what's in your strategic plan. And then how do we shift from inpatient to outpatient? You know that paradigm is shifting, and we need to make sure that we're on board with that. One of the things that I learned of recently is a area called quantitative intuition. If you're interested in that, it's really quite simple, but it's very interesting. And what the definition is how it assists leaders when there's an absence or ambiguity of data. And you know, data can be certainly manipulated in many different ways, and we know that through politics and through our own organizations. But if you're interested in learning more about quantitative intuition, it's also called QI, which is a little bit disturbing to me because we interpret that as quality improvement. But this is QI from a different perspective. But I refer you to Columbia Business School to learn more about that. So I want to talk briefly about service recovery, and a lot of you do that already. And some of the immediate service recovery that we allow is very, very important and can mitigate complaints and grievances. And we can have people who are happier in the way we've delivered care, so that they trust us in a different way. Some of the things that I've utilized in the past is obviously whiteboards. Those are important for questions. Also, it's been shown that bedside reports help to reduce call light use. Most of us, when we look at our HCAHPS scores, I always look at noise control, especially at night. And one of the ways that I've used in the past is to have a quiet time in the afternoon where there's no interruptions for patient resting. Also, leader rounding and the questions that you ask. How do you format those questions? So do we format it in a positive way, or do we format it in a global negative way? So those are just some thoughts from that perspective of anybody within your hospital doing immediate service recovery, from environmental services all the way up to the CEO. So one of the important things that I noted and observed in the most recent position I had was who was involved in the patient safety committee. And I looked at that very critically, because as I looked around the room in the meetings that we had, it wasn't really involvement. It was more of data reporting by the quality person, and it wasn't a lot of interaction. And so I started asking a lot of questions. And finally I said, I'm sure, to the quality director, I'm sure you really rue the day that you asked me to participate in this. But I think it's really, really important that there is involvement by all levels of the organization. And what we actually did in a number of hospitals I've worked with is involve staff. They really know what needs to happen, and they know what happens at the bedside, how to mitigate harm, how to change a person's opinion of what's happening with their care delivery. So I would encourage you to look at it that way. And so what I came up with were some strategic principles that make a difference, and some operational principles, and I'll go quickly through these. Make a commitment to zero harm. Engage your workforce. Make sure that patients are at the center of the care delivery, in which I look at it from a nursing process, since I am a nurse, of planning, delivering, and assessing. And then involving patients in their care, making sure that the plan of care reflects that patient involvement. And then finally, assure movement towards the interdependencies, again, of safe, high quality, and consumer-centric care. From an operational perspective, use data and transparency. So my question to all of you is, do you post your HCAHPS scores? I know where I was, and when I said, let's post those scores, people looked at me with horror. They said, well, they're not the best. Well, yeah, they're not the best, but people are competitive. Providers are very competitive. And when people are aware of what your scores look like, it's one motivator to change those scores to be better. How do you drive your goals to transform your culture? How are leaders involved? Our leaders are the only ones involved, our employees. How are you measuring burnout? If you have employees who have been at your hospital for many, many years, there is a tendency to wish the environment looked like it used to. Well, it can't. So how are you helping those employees move along? How are you encouraging wellness? What does your employee satisfaction survey look like? How are you developing employees at all levels of the organization? And do you have a succession plan? And who are those people in the succession plan? And then I'd like to encourage you to focus on accountability and action. And a friend of mine, Linda Galindo, who you may be familiar with, her statement is tell the truth, hear the truth, and focus on what matters. Accountability improves results. And then the last is to discuss the principles, and not the principle of the school, but the principles commitment to an environment of safety. And what do I mean by that? What I mean by it is everyone is responsible for patient safety. It's not the director of quality. It's not just the provider who cares for that patient, but it's everybody. And the analogy that I have, it's similar to surgical timeouts. So in other words, you don't have a title. If I'm an EVS worker or I'm delivering a plant to somebody and I see something that just doesn't look right, we must speak up, say something without retaliation. And there must be a shift from silos to enterprise-wide transformation, which actually yields excellence and trust on behalf of your consumers. So I've approached this from a very global perspective and what I have done in the past. And please think of questions. I'd love to hear from you, and I'll turn it over to the next speaker.
Perfect. Thank you, Diane. I appreciate your comments, and I really love your last comment that safety is everybody's responsibility. To your point about being accountable and responsibility for patient safety, that is a global effort in healthcare. So very much appreciate all of your comments. Again, we do have some questions that have come in. We'll save those until all of our speakers have had a chance to speak. So thank you for the questions that have come in thus far. Okay, I have the honor of introducing our next panelist, Todd Hebert. Todd is the Quality Improvement Specialist for Powell Valley Healthcare in Wyoming. Todd has served as Quality Improvement and Risk Management Specialist at Powell for just about 2 years, which is a critical access hospital that also has long-term care, assisted living, and a medical clinic. In addition to quality improvement and risk management responsibilities, Todd also serves as quality improvement, safety, infection prevention, antibiotic stewardship, and customer service committees. So as many of us in small and rural health, we tend to wear many hats. So Diane and Todd are not immune to that. So Todd is going to speak to us a little bit about false data and false data collection, distribution of data, some analytics of data, and current falls prevention projects. So with that, Todd, I'll turn it over to you.
All right, thank you, Tom. Yeah, I wanted to speak a little bit about some of our falls projects and kind of how we got to those particular projects. Of course, the data collection is important. With any database, your information that you're pulling out, your data that you're pulling out is only as good as the information that's put in. With that in mind, we expose all of our new employees to some basics of the Safety Zone portal during new employee orientation. So they kind of have an understanding of what it is, what we use it for, in just some basic how-tos. Another thing that we really look at is timely reporting, especially with our falls data collection. Anytime we have a fall event, as soon as the individual's been evaluated and any medical attention's been given if needed, would have you, whatever protocol needs to be followed, per policy, our staff immediately conducts a post-fall huddle. And with the information that they derive from that, kind of some of the may have happened, what was observed, documentation of any type of injuries, things like that, we want those in the system immediately, where they can go out to the folks that need to see them and can be reviewed. Now, talking about the data collection, the staff that's inputting this information, it's kind of a given, but one of the important things that I wanted to bring up, when we move on to the next step of the distribution of this information, is to make sure that they're included, that loop is closed, and they get some feedback on what they put into the system, and doesn't go off into the computer and is never seen again. Our data goes to the state. We pull specifics from the Safety Zone portal for a quality improvement initiative through the state. That's where we pull our numbers, as well as our board, our quality council, our safety committee, falls committee. And from there, it's filtered on down through the department leaders to the frontline staff, so that they know what has happened with particular events. Was there any corrective action that needs to be taken that was maybe found? We can have some discussions about policies. Do we have something that's maybe not working? Those types of things. A lot of that frontline staff is also, members of that falls safety committee, that falls committee, as well as the safety committee where we report these. So there's a lot of involvement with them to help find solutions. And the example I have, first thing that came to mind was the recent initiative we started working on falls back at the beginning of this year. What the falls committee did was took a couple of select individuals and started extracting data from falls. We looked at about 2 years worth of history. And from that data, what they were able to pull was, and this was in our long-term care facility, they were able to pinpoint some specific residents that were falling frequently. Then from there, they started looking at when were the falls happening. Do we have particular days of the week, things like that. And then they went a little bit further and were able to actually pin down some times of the day. And surprisingly, we found that the majority of our falls were occurring between 3 and 5 p.m. So that's kind of where this new falls prevention project came in, that our falls committee folks were able to put together with the particular individuals pinpointed that were having frequent falls in the time of day. We put together a volunteer program where we bring folks in during that 3 to 5 p.m. Now, they're not patient care volunteers. They're strictly there. They interact with the patients. They play games. They may read newspapers, things like that. Just have some one-on-one discussions. But it's just that another set of eyes, so that if that patient wants to get up, needs to get up, wants to be moved from the recliner to the wheelchair, what have you, they can call and have a nurse or a CNA come in and give them that assistance, where we are hoping to reduce some of the falls. And even looking back a little further, we were reviewing data just at the beginning of the week here, and we've seen a significant reduction in falls with major injuries over the last 4 quarters. And, again, this was from data we had looked at and worked with particular individuals on strength training, things like that. So we're just getting our first volunteers out on the ground here this month. Hopefully we'll have a few more on board in the coming weeks, and we'll be watching the data and looking at things to see what the impact is, and if we found something that's going to improve, our fall numbers. That's kind of all I have on the fall. So I'll turn it back over to Tom.
Perfect. Great. Thank you, Todd. Very much appreciate that. Yeah. And there's already a question in here, particularly about that program. So great. Very, very much appreciate your comments and your sharing your project with us. All right. We have one more speaker, and then, as promised, we'll get to our questions. Iris Fearing is our third speaker for today. She's the Director of Quality Services at Waverly Health Center in Iowa. Iris has served as the Director of Quality Services at Waverly since 2005. In her role, she guides performance improvement, organizational excellence, risk management, quality reporting, organizational assurance, and accreditation efforts. So as our previous 2 speakers, not shy to wear many hats in her roles at Waverly. Prior to assuming this position at Waverly, she spent 14 years in biotech manufacturing, working in all aspects of environmental health and in the safety arena. Additional experience includes development and implementation of sustainability management systems in conjunction with existing quality systems. So nice perspective on the enterprise and system approach. And so with that, Iris, I'll turn it over to you.
Thank you, Tom.
Well, I'm sorry. I'm sorry to interrupt you, Iris. I just wanted to give the audience what you'll be speaking about. So I'm sorry to interrupt you, but Iris has a couple of things she'll want to speak about in relation to fall prevention and ED workflow as it relates to things like admit time decisions. So sorry about that, Iris, but now I'll turn it over to you.
No worries. Thank you, Tom. Thank you. Hello, everyone, and thank you for attending and participating on today's call. It's good to be here. So I'm at Waverly Health Center, and we are also a critical access hospital in northeastern Iowa. We are said to be the 2nd largest in the state, so we have quite a few things happening. We have inpatient, including a birthing center with an affiliated women's clinic. We also have surgery for inpatient and outpatient, and we have several clinics associated with us as well. And as part of that, we employ 41 providers, 20 mid-levels and 21 physicians. So we've got a lot going on, and that includes a lot of also visiting specialists and specialty clinics that hang out with us too. So with that said, I wanted to talk about a couple of projects and work that we've done over the years. One is kind of a tag on to Todd's presentation on falls. So we've also been looking and working on fall prevention. I wonder that that's universal. We are driving to zero. That's what we want to get to. I wish we could say that we were there, but we're not quite yet. We're working on it. And this really started with us back in 2011. We had obviously been watching falls and staying within the normal, quote, rate, end quote, that you think of. But we had 3 falls at that time in quick succession that involved some major injury to the patients. And that kind of opened our eyes to say that we really had to do something different and more with what we had in place at the time. And what we did in that root cause analysis and finding of those events was we really realized we did not have, for example, a fall scale in place that was evidence-based. Our scale at the time for risk of fall to the patient was kind of homegrown, and it wasn't evidence-based. So looking at that, we selected an evidence-based scale, and we implemented the Morse scale at the time. And we did a couple other things with educating and identifying safe patient handling opportunities for staff. So we did a lot of work on that and saw the rates decrease for a little while, but as we monitored the data, we saw them go up again about 2 years later. So in 2013, we reassembled the task force and the project and basically started all over again with root cause analysis of what we were seeing at the time and looking at the data that was put into, we also used the Healthcare Safety Zone portal. So that was a big help for us in watching that data and also benchmarking against state data that we had, as well as the BFEPs at the time. So based on the second go-round, we implemented also post-fall huddles, and I know Todd mentioned that in his presentation, and that has been very helpful to us. We implemented elements of that actually into the reporting portal so we could know right away whether the huddle was done. So we wanted the huddle done right away after, with staff involved, with the patient and or their family as needed, to help understand really what happened. And a root cause analysis then was part of that process as well. That helped us identify some more things to put in place after the fact. So as we went on then monitoring the data, we also identified some specific things about some of our falls that were happening. And during one portion of data analysis, we discovered many falls were occurring with our nursing home patients that had come over from the area nursing homes. And they were falling in the evenings from a timing perspective. Beyond that, we identified that they had some issues with medications at night called sunsetting, where they became a bit confused and disoriented in the evenings and would think they'd be at home and would get up to go use the restroom or whatever, and end up falling without calling or asking for help because they forgot where they were. So we were able to actually modify our admission assessments to include questions to the family and or patient and or nursing home, whether the patient had any issues with that. So that was a good example of identifying items off of a root cause analysis and using that data to drive some follow-up. We've also started looking at falls on the outpatient side. So that's our next generation, is really looking at all patient falls and visitor falls. But from a patient perspective, we found we had some falls happening in our radiology department. And throughout root cause analysis, we understood that we really weren't assessing some of our patients coming in to know if they needed help with a wheelchair or with a gait belt standing up, say, for example, for a mammogram or getting onto the exam table for an x-ray or a film. And what we've put in place after the task force started, and that was in 2017, late 2017, we actually put in place a registration assessment for outpatient falls. And we focused that on our radiology patients initially, and it allows a risk to be identified based on 4 questions that the patient is asked. And the admissions folks do that, and the questions are very simple. Do you feel dizzy, lightheaded, or weak today? Do you need help walking? Have you fallen within the last month? And do you feel like you are at risk for a fall today? So based on those questions, a flag is raised, and the staff then know whether or not to help with fall prevention for that patient. Some of our challenges in that project were actually getting buy-in from staff and helping understand who does what in that process. We implemented it mid to late last year, and we are actually watching data, and our post-implementation is in process. So we're hopeful that this will be able to be spread to other departments in some way, shape, or form to help reduce those numbers too. So we are measuring everything through the portal. We've added elements of these items into the portal to help us track that data, and really are letting data drive the decisions and whether it's revisited or the success, for example, of those projects. So another quick item I wanted to touch on, and this also touches on that area of focus of ability to identify the specific areas of concern, tying into our ED2A, it's core data that we track, and it is the admit decision time in the emergency department to the time the patient is actually admitted. And that is to our inpatient floor. And this actually started back in 2016 when we were looking at the data, the core data from internal abstraction as well as what's published out on Hospital Compare. And we were actually better than the national average. And it was something that was of note to us, because we thought originally, well, we're doing pretty good in that regard. But as we started talking about it in our clinical quality and practice group, we identified that the med-surg folks were actually a bit uncomfortable with that, because we understood and identified that some of our ED patients were getting over to med-surg a little too fast for their comfort, meaning they weren't quite ready for them yet. And some of the patient handoff wasn't quite as comprehensive and complete as it could have been. So as we dove more into that project, we actually identified that med reconciliation was one of the opportunities. And some of that information was not able to be gathered in the ED. We understood that, but sometimes we could gather it in the ED, but it wasn't quite comprehensive enough. So by the time the patient got over to the med-surg floor, it made more processing and effort on the med-surg side for med reconciliation, among other handoff materials. So we were really able to deep dive into that process in the emergency department to help identify at 2 in the morning when a patient comes in, for example, and all the pharmacies are closed, how do you do an evaluation on med reconciliation that's pretty accurate? And what can't we get to? And can we get that information over to med-surg to know that, okay, at 8 a.m. when things start opening up, here's what we need, because the patient and the family members weren't quite sure on that particular dose of medication, for example. So a lot of good learnings through that process. And we're actually still working on it because we've identified opportunity really since then to help the departments understand where that process starts and ends, knowing that MedRec is always a challenge across the board, really from a comprehensive accuracy standpoint. We actually used checklists and audit forms that we created to help understand the success of that program, or process, I should say, and watch the core data number as well. Ironically, as expected, that number has gone up. We were, I think, just under 30 minutes back in the day, and we're up to 49 now. So we knew that would go up, and that is expected and understood, but our measure of success really is the better understanding of the med rec for that patient and that patient safety, and the staff members having that in process and understood who's doing what and having it done more efficiently and effectively. So sort of to wrap up here, some of the takeaways, not much different, supporting what Diane and Todd have already said. Data-driven improvements. We really use data to drive what we want to work on and to show us whether we're meeting or not meeting our goal of that original problem statement for the projects that we identify. Get the experts involved. In these projects, we use task forces. That's kind of what we assemble for improvement efforts, and we try and get it done as quickly as we can within 4 to 8 months. But you get experts involved, your content experts, and we try to involve a patient as well in these because the patient perspective is so critical. And the ongoing monitoring being very, very important. And when you get something done, you can't assume that it's fixed. You need to have your identified measures and a way to track it. In many cases, we use the portal for process items, for risk items, and we're able to really deep dive into that data. And once you have that identified, that is very helpful going forward. So happy to answer questions, but at this time, I'll turn it back over to Tom, and thank you.
Great. Thank you, Iris, and thank you all three of our speakers for presenting today. So we have about 12 minutes left, so we'll move right into the questions and answers. There's a few general questions. We'll save those to the end, but there are some very specific questions, and we'll work. I'll try to work backwards here. So Iris, we'll start with you first, and then we'll end with Diane. And Todd, okay. You're still in the middle. Iris, the one question that came up is, can you share and repeat the 4 questions asked for risk assessment at registration?
Yes, of course. So the first question we have is, do you feel dizzy, lightheaded, or weak today? And then we have an example, due to medications or because they haven't eaten, so for any reason. And these are just yes or no questions. Number 2, do you need help walking or standing longer than 5 minutes? Number 3, have you fallen within the last month for any medical reason? And number 4, do you feel like you are at risk to fall for any reason?
Great, thank you.
You're welcome.
And this is another question for you, Iris. You mentioned post-fall huddles. Do you document that data in the portal? I believe you answered this, but there's just I guess, a clarification question about documentation of post-fall huddles in the portal.
Yep, we do. We document, we have a question in there that's a yes, no. Was it completed, yes or no? And they then mark it yes, and was it attached? So we're able to see at a glance whether the staff did it. And the post-fall huddle itself is a separate sheet that gets filled out by hand. So we felt it was easier for them to have it on a piece of paper that they can walk into the room and do it. They don't have to pull up the computer, et cetera, et cetera. So when that is completed, we will scan it and attach it to the portal event.
Great, thank you. Okay, Todd, a question for you regarding state reporting. And it's a general question in terms of how do you do that, and I think it's in relation to, you were speaking about you use data from the portal to satisfy state reporting, and folks are just curious how you do that.
That's correct. You know, whether we're pulling for our quality initiative through the state, or we're preparing for one of our committee meetings or something, we're going about it the same method. You know, we'll look at our specific time frame and pull all of our falls or whatever we're tracking right out of the safety zone portal to generate our numbers.
Great, thank you. And more of a statement versus the question, Todd. I'm actually personally also curious about this, but folks are interested in hearing about your volunteer program for the peak times where you had the falls. I believe you said it was between 3 and 5 p.m. We know things like, you know, one-on-ones and sitters can be expensive and they're not always reimbursable. So the use of volunteer program, there seems to be very interest in seeing how that program goes. So please share with us as you collect data there.
Yes, definitely will.
Thank you. Okay, Diane, a couple questions for you. One question came in, do you use the portal for rounding? And I believe you were talking about bedside rounding and leadership rounding, and the question was, do you use the portal for that? I'll say generally, and then Diane, you can speak to specifics on you know, leadership rounding and the importance there. Generally, the healthcare safety zone portal you are able to capture things like environment of care, leadership rounds, safety rounds. So we know that many providers do use the system to capture that sort of workflow of conducting the rounds. So Diane, if there's anything you have to add there in terms of you know, data capture with respect to leadership rounds.
Well, I can't give concrete information because we just started doing bedside rounds. As far as integrating that with the safety zone portal, that was not done yet, but it certainly is an initiative that is for the future. We had, just to give a little background, I'll do that in Reader's Digest version here, is that there was a lot of pushback when I suggested the bedside rounds from nurses who felt that the information that needed to be shared with another nurse shouldn't be shared with the patient. So it took some time to get that moving. So the next step is to integrate that with the safety zone portal. Very easy.
Great, thank you. One more question for you, Diane, and then there's a couple of general questions that I think are applicable for all three of you. So that's the order with which we'll take the next few questions here. How important is it for notifications timing? And I believe, Diane, that's a question for you, and it was in relation to being able to be notified of things timely. And it's sort of a general question, but I think the question is in relation to how important is the notification of timing. And you were talking about a variety of things for folks to think about. So OR safety and burnout and workplace violence. And once you capture that data, the importance of timely notification. And so can you speak to that at all?
Sure. I think that it really falls back on education. One of the things that was discovered at a number of the critical access hospitals, as well as the PPS that I was at, was the fact that the mandatory compliance line and how frequently was that used. And there was an analysis of why wasn't it being used, because there was a sense that there were issues happening. And all of you know that within a smaller facility, there's a lot of information that is shared at what I call the water cooler conversations that maybe should be looked at. And so as a result of that, there was a lot of education that was done to encourage people not only to use the compliance line, but to share that information with either their leader or someone else they felt comfortable with, i.e. the director of quality and risk. So we saw an exponential growth of reporting. And then it was sorted out by the grievance committee. And so whether it was a patient grievance or it was a staff grievance or it was a concern by staff, all of those were triaged, if you will, by the grievance committee. So I think notifications went up, and then we also had a software program that we used to self-report. So I think there's a lot of mechanisms, but you're trying to break down the silos, the fear, and the intimidation or the retaliation. So it goes back to the just culture type of thinking. I hope I answered that question. If not, feel free to email me, and I'll be happy to talk with you.
Great, thank you, Diane. Okay, we have a few more minutes left here. I'll try to combine a few of the questions. I'll ask the questions. This is for all three of you, and so you can have a minute or two to respond here. I'll read the two questions and give you a moment to think about it. They're heavy questions. So, one is, do you see other aspects of reporting that may have developed as a result of small changes, small successes? That's one. And then the other question is has your culture been affected or shifted by an increase in reporting? And so those are the two questions, and then so I'll give you a minute or two to think about it. And so Diane, we'll start with you, then we'll go to Todd, and then we'll conclude with Iris. So again, the two questions are, do you see other aspects of reporting that may have developed as a result of small successes? And has your culture been affected, or has it shifted as a result of increased reporting?
I think, again, I just want to go back to that trust factor. A trust factor is inclusive of internal customers and external customers. So again, it went back to education, involving the staff in developing an education module that addressed why aren't you trusting your leader or your manager to tell them what's going on. So that took some work, but then again, as far as culture change, we attempted to move that pendulum in a way that said, okay, we're improving trust between each other. How will we improve trust with our consumers? And that includes providers, which is a challenge. All of you know that, but it's a work in progress. It's not going to happen overnight, and involving the right people is the critical element.
Great, thank you. And Todd, we'll move to you.
Yes, you know, on as far as our culture here at Powell Valley Healthcare, we really have worked on the self-reporting, and it, you know, whether it be from the the providers or medication errors, what have you, but the reporting, you know, it's stressed that it's non-punitive, and I think over the last couple of years we've really seen a positive improvement with that. There's not that, you know, there's not so much concern, you know, about reporting, you know, surgical site infections or med errors or what have you. So that I think is a positive. And, you know, and the other question, as far as some of the changes, I think there's been numerous improvements in changes in the way that we track things and so forth here. So yeah, it definitely makes you look at things at the process and gives you opportunities for improvements.
Great, thank you. And Iris?
Yeah, I agree with Diane and Todd. Some of the things that we've seen over the years is really an increase in the use of the system for various reporting. So we've really expanded beyond just patient safety events per se to tracking process improvement projects, that if somebody is interested in creating a project or working on something, we actually have a tracking form for that that gets submitted and gets auto-routed to the leaders that need to be in the know, auto-routed to the Patient Safety Council to say, hey, we need a patient rep, we need this expert, and it really launches that process for the project implementation. We've implemented tracking on peer review elements, so that's actually in the system as well, and it auto routes and auto tracks, so we're able to track the risk items on what peer reviews are coming back, are they acceptable, questionable, inappropriate, and we run it by area, by provider, by patient type, so we can really track and see what's happening that way. Recently, we've started using the system for security events, actually tracking in that regard, so we can get a sense of historically what's happening in what departments and what types of things. So yes, very much so in terms of that culture, and it really helps create more awareness and more timely follow-up for patient safety and staff safety, because we track employee events, injury and illness events as well in there. In the end, we want to get to really a culture of behavioral-based safety where we can walk the talk and just keep that safe culture all the way around.
Yeah, perfect. Great. Thank you again, all of you, for your comments there. That does bring us to our close of our hour here, and brings us full circle. So we hope for all of you who were able to listen in, stick with us through the whole hour. We appreciate that. We hope you got some new ideas for things to think about going forward, or reinforce some things that you've already been doing. And we hope that was helpful for you as you advance your journey of safety. So Iris, Todd, Diane, very much appreciate your thoughts and comments and sharing with us today. And on behalf of myself and all the folks here at Clarity, thank you all for joining our webinar today, and have a great afternoon. Thank you.